I think we have a good number, and just so we have enough time for questions, I will start right away. All right, good afternoon, everyone. Welcome to the Yale Sleep Seminar Series. My name is Shritika Sapa. I'm one of the faculties here at Yale. Just some brief announcements before I introduce today's speaker. Please take a moment to ensure that you're muted. In order to receive the CME credit for attendance, please see the chat room for instructions. If you have any questions or comments during the presentation, please use the chat room, or you can unmute yourself at the end of the talk and ask questions, and I will moderate the session. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And today I have the extreme pleasure of introducing Dr. Bethany Lussier. She received her medical degree from Robert Wood Johnson School of Medicine in New Jersey. She completed her internal medicine residency from Columbia University in Stamford, Connecticut, and then received her fellowship in pulmonary and critical care medicine at Boston Medical Center and her neurocritical care fellowship at UT Southwestern. Dr. Lussier is currently an associate professor of internal medicine at UT Southwestern Medical Center and a member of its division of pulmonary and critical care medicine. She serves as the director of the Neuromuscular Pulmonology and Home Ventilation Clinic at Parkland Health and is also the director of the Parkland Hospital Medical ICU in Dallas, Texas. She has lectured in multiple courses in neuromuscular disease and home ventilation, which I love, regionally and nationally. She's also the co-director of an international virtual didactic discussion based on home ventilation called PEEPS Talking PAP, case-based home ventilation didactic series, which is also excellent. Dr. Lussier has received many teaching awards, with recent one being the American Academy of Chest Physicians Distinguished Chest Educator Award, recently in Boston, 2024. She has also authored many publications. So thank you very much for being with us, Bethany. And without any further delay, I would like to hand it over to you to share your expertise on managing chronic respiratory failure in neuromuscular disease, choosing the right target for NIV. And here you go.
Thank you so much. These are a little difficult talks to make because I get quite nerdy about this stuff, and so I could wax poetic forever. But actually, it's a lot of fun to go through some of the aspects of home ventilation, and I took out most of my research to make room for some clinical cases because I think it anchors us a little bit better. So as things pop up, if there are questions, please don't hesitate to stop, because it sinks in better if you actually have questions and try to apply it as we go through. This was the disclosure and accreditation. I get some consulting fees from Biogen and the NFL, all for consultations that are completely unrelated to this particular topic. What I had hoped to go through is kind of general approach to neuromuscular disease. You guys have been exposed to neuromuscular disease. You got the basics of neuromuscular disease down for the most part. It's about fine-tuning what we're actually trying to achieve and making sure that we're hitting our targets by defining those targets in general to determine whether or not we're actually being successful in the management of our patients. I'm just going to kind of set the stage here, just to kind of anchor us here. 68-year-old man with Charcot-Marie-Tooth, so progressive polyneuropathy. I don't know how many of us are pulmonologists at the core, some maybe neurology, some maybe internal medicine, but this man, you can see the chest x-ray here with extensive revision of spinal hardware twice, and he's got significant thoracic restrictive disease. I usually explain it to my patients when you're getting these pulmonary function tests. What we look for in terms of restriction is how much air you can move in and out of your lungs in a single big breath, right? So that's going to be your forced vital capacity. It's probably one of the only numbers that really matters when you're looking at these patients. With neuromuscular disease, you'll make sure it's not something else like COPD and they have no obstructive component. But when we're comparing that FVC, you can see it's very small. And this guy, he's about 37% of what's predicted for his height and his age and his gender. You can also notice his MIP at the bottom there is -19. That's pretty weak. And so those numbers are technically what's going to tell us, one, he's at risk for related hypoventilation. Sleep-related hypoventilation and daytime ventilation may be an issue as well. He could be expected to be dyspneic. And those are the patients we're going to pay the most attention to in this particular talk, whether it's CMT or another disorder. We know that it's variable in different neuromuscular diseases, right? Not all neuromuscular disease is created the same, and not all restrictive thoracic disease is created the same. You can see somebody who has severe kyphoscoliosis or severe scoliosis, pectus excavatum, they're going to have very different physiology from somebody who has an acute spinal cord injury, who may anchor the diaphragm differently. And then that may very much differ from somebody who's got muscle disease where there's focal issues, or perhaps a global atonic muscle that you're working against. And so the distribution and the onset of the disease will actually determine the rib cage and the inspiratory muscle dynamics. So usually the rib cage will open up, pull up and forward, and the diaphragms will pull down globally and concentrically. But that doesn't happen if it's abnormally developed or it's not anchoring onto the ribs or the chest wall properly. Then we would throw onto the mix that positionally there may be variation as well. So we know from studies in anatomically normal adults that when you lie down, your forced vital capacity, the total amount of air you can move in and out, and the strength at which you can move it can drop. And it will drop in a normal adult. Your FRC and your FVC will drop significantly from sitting to supine position laying down. It will drop even further if we put you in Trendelenburg. And we know that in normal adults, but it can be markedly exacerbated in patients who have neuromuscular disease. And that's why we say when we're evaluating these patients, we're going to take that FVC in the sitting position. We may take that NIP or SNP in the sitting position. And then when we lay them down flat, we expect to see greater than 10, 12% drop. It's going to be worse than that. This is also what puts them at higher risk for nocturnal hypoventilation, right? So when we take a normal adult and we say lay down flat, you expect there to be somewhere in the 6 to 10, maybe higher range of a drop in FVC from sitting to supine. If I take that drop and now I put you into stage 2 sleep, I'm going to get an additional 10% decrease in your FVC. Now, if I put you into REM, again, normal adult, you're expecting to be another drop, an additional 20 to 22%. So somebody who starts off significantly high, now your vital capacity is probably dropped by at least 25 to 40% in a normal adult. Now take someone who's working with a half functional diaphragm or lack of chest wall mobility at all, and they're quite stiff. And so they may have a greater drop just from sitting to supine. They may drop by 25%. So if somebody's starting at an FVC of 75%, you drop to 50% when you're lying down flat. Who knows how far they drop in stage 2? Never mind when you get to REM and the only thing functioning is your heart and your diaphragm. If that diaphragm's now working at 12% of normal, you can see the significance of that, and you're going to see aggravated desaturations. And then on top of it, you may get some upper airway stability issues, which can be a pretty dominant feature in some of our patients who have certain types of muscular dystrophy or bulbar dysfunction related to neuromuscular disease. I'm sorry for the delay in my advancing here. I had this problem before I started. So this is kind of what you may see, right? The REM associated desaturations you can see in REM sleep. There can be pretty dramatic desaturations, and that certainly would be aggravated in somebody who has neuromuscular disease. When you're putting this into perspective, a lot of us who have seen inpatient, we can kind of extrapolate what happens on the inpatient, because when you see somebody who comes in with acute neuromuscular, acute hypoxic respiratory failure, or acute neuromuscular respiratory failure, things happen and fast forward. But we're talking about patients who have chronic neuromuscular disease, and usually it's progressive, or they hit a tipping point and they decompensate. But the process actually holds true. It's just whether you're doing it over the long term or you're doing it over the short term. So if we look at there was a great study that came out that was actually looking at work of breathing and diaphragm power in patients with acute respiratory failure. And they were actually trying to address that power by offloading onto a machine. So what they were looking at is that terminal phase of respiratory failure. And they noticed that there was an initial shift where you actually start to have a high amount of low frequency power and you drop off on high frequency power. And then all of a sudden you have your respiratory rate shoots up, it skyrockets, and then you start having abnormal respiratory movement, and that's early sign of failure. So that respiratory rate shooting up, and it becomes rapid shallow breathing, and your minute ventilation starts to drop off after that. Your CO2 starts to rise, you get acidemia, and then there's a terminal drop in minute ventilation and respiratory rate right before they try to die. And the only way to get them out of that terminal cycle in acute respiratory failure was to rest. And that meant putting them back over to full vent support, or by hitting them right here where that respiratory rate started to go up and offloading the work associated to shift them back into high frequency power. And to do that, they required pressure support. So if you cut them off early, you can head it off and you can mitigate that natural decline. But if you waited too late, the only way to do it is to put them all the way back on full support to avoid the terminal spiral at the time of death. But we're looking at this chronically, right? We're looking at chronically fatigued muscles. And so the question is always when, and when does it matter? When do you intervene? Do you wait till the respiratory rate goes up? Do you wait till the minute ventilation drops off? You certainly don't want to wait till they have low minute ventilation and low respiratory rate, but the same process may hold true. And we don't really know because every neuromuscular disease is a little different. You can see various types here with the pectus and the anatomic abnormalities, and this right hemidiaphragm abnormality. I don't know whether that's chronic or progressive or not. Somebody with SMA, like on the far right. And when to intervene on these patients is going to be very variable. So we're trying to talk about an entire cohort of neuromuscular disease, but there's huge variation in it. And we don't necessarily know the exact right time, which is problematic when we're trying to develop guidelines that are all encompassing. And unfortunately, from guidelines comes our insurance reimbursement. And so it's, sequentially, we actually need more information on this. But if you look at the FVC progression, right, FVC percent predicted for a patient who has DMD, for example, you can see the rapid decline that happens towards the end, and the progression varies depending on the clinical features of that patient and whether or not they've had interventions, whether they're on steroids, whether they're getting non-invasive early. So you can see the natural trajectory can be very variable, even within disease states. You can see our cohort with FSH. Some of them decline very rapidly, some of them decline very late, but they all have a faster than normal decline in FVC. And the question is always, if we intervened here, would we have a better outcome than if we intervened here? And the data suggests yes, but it's very hard to tell because you're trying to apply it to this entire cohort. And it's just difficult to see. And then the question is always, again, we were talking about muscular dystrophy, and now we're talking about motor neuron disease. If you're talking about SMA, does motor neuron disease respond the same way to respiratory support? Does ALS respond the same way that somebody with Duchenne's is going to respond, or somebody who has just diaphragm paralysis from a single nerve palsy? And it's not actually clear. It's not as clear as we'd like it to be. But we know that it does improve survival overall in patients that could be lumped in to either muscular dystrophy or progressive motor neuron disease. We know that for sure. And it's been shown in post-polio, it's been shown in CMT in smaller cohorts, but there's a clear survival benefit. And we were able to prove that enough. And so they stopped questioning whether or not it helps. And they said, okay, we will approve your guidelines. Yep, sure, we will pay for this non-invasive support because it's made such a difference. It's harder to show in ALS when you group bulbar and non-bulbar together. But even if you look at here, the marked differences we made before and after we started non-invasive ventilation and the survival, it's absurd, really. So nobody argues it anymore. We all know we should do it. We all know we should be on non-invasive ventilation to prevent respiratory failure in these patients. But the question is, okay, I know I should, but how? And am I actually making a difference by doing it? Am I going to achieve that survival benefit just because I put somebody on non-invasive? It has to be a good effort, right? It's got to be done correctly. The guidelines don't match up. So the guidelines, again, they're targeting on what we think is the right thing to do with the limited evidence we have. And that was probably the best survival data we have. And so we extrapolate that and say, okay, well, that applies to all patients with neuromuscular or thoracic restrictive disease. Let's apply this criteria. And we want to make sure insurance companies believing us and we get an early start because we think that's probably better. And so let's ask for it at a normal FVC and symptoms. And so far, the insurance has not actually bit on that. And none of the recommendations have actually gone through, because if you look at what the actual companies will cover, they want to wait till you actually develop some signs of hypercapnia, which is probably a very late finding for most of our patients. They want to wait till you have signs of hypoventilation or severe apnea. And they want to make sure there's no other contributing factor before they're willing to actually say, yes, okay, now we're going to start helping you out with some non-invasive ventilation. So the recommendations are based on a lot of presumption. And I think whoever's in charge of insurance reimbursement has picked up on that. And so they're making us hold on until we can really prove that everything else has failed, unfortunately. So we're kind of up against a wall. So we got to be a little creative about getting patients to qualify for it in the first place. And I'm sure you're all familiar with that. It brings up the concept, though, of what are we trying to achieve in these patients? And I'm going to throw this concept out there it's tossed around. You won't see it much in the literature, but there's this concept of diaphragm rest. And it's actually what we're technically trying to achieve with all the measures, just we all do it a slightly different way. And all the experts have a lot of opinion on this, a lot of opinion. So I'm going to show you what the concept is, but I'll also tell you where the debate lays, because there's quite a bit of it. So the debate on this is, how much ventilation do you actually need and when? And so for somebody who's early in their disease process, do you take over the work of the diaphragm, particularly at night, and allow a period of diaphragm rest? Allow them to completely be backed up by mechanical support in order to rest the diaphragm, with the theory that it will improve survival for the long term, improve morbidity and mortality. And there's a lot of opinion on it. And then the question is, how far do you push diaphragm rest? Does it need to be complete rest? Or are you just trying to achieve relief of the hypoventilation itself? And that's where the debate ends up coming in. But I'll show you some of the reasons why somebody may push harder towards one end or the other. The arguments against diaphragm rest is that for periods of night, if you're completely dependent on a machine to do the work of your breathing, will you lose that muscle and will you make something progress faster? That's always going to be the debate. And there's people who swing very heavily on one side or the other. And so we will talk about that in a second. There's limited studies on this. There's studies that you could probably, again, extrapolate data from small cohorts. There's short-term studies that look at correcting ventilation with or without a backup rate. And most of those are looking at whether you're correcting saturations, you're correcting end tidal or transcutaneous CO2, sleep efficiency, adherence, quality of life, things in the short term. So just getting somebody onto non-invasive ventilation or a RAD device, getting them set up, and how quickly I can correct some sort of parameter. Then there's other short-term studies where people are looking at acutely ill patients in the hospital, right at a terminal period, and they're looking at periods of neuromuscular decline, not necessarily neuromuscular disease, but looking at neuromuscular weakness associated with respiratory failure, looking at work of breathing calorimetry studies. And those are actually kind of helpful studies to look at when you're talking about neuromuscular weakness and offloading that work and resting that diaphragm. They can be useful studies. The long-term studies we have are very limited. So the long-term studies look at the utility, the survival benefit from initiation of ventilation, and almost all of them are done with a backup rate, almost all of them. Because if you're looking at survival, you're looking at progression of disease, and at some point, people lose the ability to trigger, and they get wildly, they start to wildly hypoventilate. And so all of those studies, you have to take into consideration that they're all done with a backup rate. And so when we make these assumptions that you need a backup rate, it's predicated on the fact that most of the survival studies are done with backup rate for those reasons. When we're looking at sleep in general, right, we're looking at, I talked earlier about that terminal spiral that we're looking at, and also the fact that when you're going into your deep sleep, your tidal volume is naturally going to decrease. And in neuromuscular disease, we're going to see that exacerbated, right? But we also see from several of the studies, but this one by Burke, looking at the sleep patterns in somebody with neuromuscular disease whose tidal volume is starting to decrease, you'll see that rapid rise in respiratory rate. And you can see that in resting respiratory rate in patients who are awake or in deep sleep. So you can see that pretty dramatically in neuromuscular disease when you compare it to, I will say normal, but a normal patient undergoing, you'll see that rapid. And this is a patient who has Niemelin myopathy. And you'll notice how fast this is in N3 sleep. and the rapid respiratory rate averaging somewhere 28, 29 breaths per minute. And then you see down at the bottom, the saturations are pretty low. They're in the 90, 92 range. And the transcutaneous CO2 towards the end of that starts to kind of creep up a little bit, 40, 42. And this might be a typical pattern you see with somebody who's in that early phase of chronic respiratory failure, particularly when they're heading to sleep. We know that when we look at patients who are starting on non-invasive ventilation, this was a pretty good study, and they were comparing VAPS to BiPAP with a backup rate. And that's another big debate that's going on in the community, trying to figure out, well, what's superior, because VAPS does have a backup rate built in it, but people don't really rely on the backup rate for the same reason. And we always talk about BiPAP ST with a backup rate. And what they were able to show was that there's slightly higher tidal volumes and the rapid shallow breathing index tends to fall, indicating more efficient breathing when they're set up, right? So this right here, your respiratory rate starts to fall, and then your minute ventilation actually improves and it just becomes far more efficient. And when they compared the two, there really wasn't that much of a difference between BiPAP ST and VAPS. We were able to achieve the same thing. This is kind of just another way they were showing the same thing. As we get to a good tidal volume, right? You get to 8 to 10 mils per kg ideal body weight, your respiratory rate will start to come down because you're ventilating appropriately. So that patient will slow down their respiratory rate and meet your backup rate. But what they were able to show at the end of this study was really interesting because like I said, they were being able to show that there's less rapid shallow breathing and there was no difference between VAPS and pressure support. But they showed that as time went on, there was more of a concern for failed trigger and this cycling problem that we can talk about in a little bit. But what the real concern was that with progression of disease, ineffective triggering could be addressed by the backup rate, but it wasn't sufficient alone just to provide the backup rate. It really required attention to the ventilatory support and the inspiratory times that were associated with it. So it's an important concept that it's not just about supporting the respiratory rate and making sure somebody's respiratory rate comes down. It's making sure that you actually have sufficient ventilation with the time of the breath to get them to the point where their respiratory rate does come down, to make sure you're providing adequate minute ventilation. So the hype, right? So we always talk about BiPAP ST. We're so obsessed with BiPAP ST. I'm obsessed with BiPAP ST. If I can get away with it, I'll totally do it. I get a little nerdy about VAPS also, but why? The question is why, right? In all the literature, nobody will ever give you a really good reason other than they have neuromuscular disease and you want them locked to a TI. And this is something you're going to hear over and over and over again. And it's important to understand why we get so upset or excited about it at the same time. We do worry that with somebody who's going to have progression of disease, that at some point they're going to start to have undetectable trigger, especially when the diaphragm is not moving particularly well and they're in their deep sleep. It may be a little insensitive and it may become atonic at some point in general and have difficulty triggering. The other concern we always have is that when you start somebody on appropriate tidal volumes and it's large tidal volumes, you may precipitate some central apneas. And so that backup rate may be important for that aspect. But the real key for these patients with neuromuscular disease is that we really want those breaths linked to an inspiratory time. It's a really important concept. If you set up a patient, I probably should go to the next slide on this, but if you set up a patient on BiPAP ST and they're breathing at a rate of 18, they're never going to have a triggered breath. They're never going to have a device triggered breath, because if you have a device set up with a backup respiratory rate of 10, it takes 6 seconds before it's going to deliver a breath. If the patient is continuing to trigger on their own, it's all going to be pressure supported breaths. And those are not typically locked to an inspiratory time. Those are cycled off when they reach a certain percentage of their flow. So it will be a shorter breath, which means a shorter volume, which you can see in the graphic here, right? It's a shorter breath if it's spontaneously cycled off. But if they're exceeding, if you have it set on a rate of 10 and they exceed the 6 seconds because they're starting to breathe slow, they're breathing at 10, 11, 12, then it will trigger a certain number of these breaths that are linked to an inspiratory time. And these are the breaths that guarantee an IPAP over a certain time. And so we focus on this, we say ST, you can prescribe ST, but you have to be prescribing ST so that they actually get some of those timed breaths. Otherwise, you're prescribing BiPAP S, right? So you're just prescribing spontaneous breaths. So it is important to do. It's important to have the backup rate, but you got to use the backup rate if you're going to be prescribing it. And that's missed a lot of times. We talk about the trigger is what brings you from the IPAP and triggers you to get up to the EPAP. And the EPAP is supposed to eliminate some of the CO2 in a circuit. And there's some nuance to that depending on the type of circuits you have. And that's its own exciting topic. But really what we're talking about is trying to get that trigger for a patient who is either still strong, headed towards weak, or really weak already. And we have to figure out how to get that machine to sense that they want a breath. And we want a certain number of them to be timed breaths, if that's the method we're going with, so that they don't have to work very hard for it, but we're also locking them into that inspiratory time. And we're not causing a problem by giving them a breath when they don't really want it. And so there's a lot there involved in the trigger, and there's a lot of ways to do it. But we want the trigger in general to be sensitive enough so that it's detecting a weak effort, especially in somebody with neuromuscular disease. The key to that is knowing that it's set weird on different devices. It doesn't translate. So usually we're using a flow trigger, not a pressure trigger. And the flow trigger is a high sensitivity. We talk about this in the ICUs, and then they went and they made everything a number. So the high sensitivity, but if they give you numbers, you got to look at them, because sometimes it means liters per minute. And so versus 1 versus 5 liters per minute may actually be very high threshold for them to get over. That's a low sensitivity. So it's something to keep in mind when you're prescribing these things. You want a highly sensitive trigger on these patients. If I'm going too far, too fast, just give me a signal so I'm not talking in circles. And we already covered this, so I'm going to move on. There was this fun study. I loved this study. It was post-polio patients who were put on a vent. This was they were looking at a short-term study, and they're trying to get these patients off the ventilator. And so they ended up putting these patients on different cycles, sort of like a weaning mode. And they compared rest versus spontaneous versus CMV. So all controlled, everything was timed, and there was no patient trigger, versus bi-level pressure support or bi-level pressure support with a backup rate. And they actually did calorimetric studies. And it was pretty cool because I looked at the work of breathing. For the most part, patients hated CMV. They do not like taking a breath when they don't want one. They don't like being told to take a breath when they don't want one. And they don't like being told you can't take a breath when they want one. But when you compare the pressure support with a backup rate and without, the work was pretty similar. And it was far better than spontaneous breathing. It's intuitive. And then they questioned, well, why is it that the backup rate didn't seem to decrease the work of breathing? And it's because the backup rate was not being applied because the patients were all over breathing it. So they were all basically essentially on pressure support. But that said, it was much better than spontaneous breathing. So we know that just offloading some of that work, it actually improved the calorimetric studies. But so it probably is associated with lower work as long as they're synchronous. That's the whole moral of that story. As long as they're synchronous, you're decreasing the work by giving them some pressure support, and you're decreasing it by giving them a rate, according to this, for what it's worth. Small study, but it was an interesting one. Again, we're talking about trigger. I'm going to pass that. We're going to go straight to the breath. So from the trigger to the cycle itself, right? So when you get to the top of your IPAP, you're going to deliver an IPAP over some period of time. It's going to cycle off at some point, whether it's timed or you're going to, when the flow starts to slow down for the patient. The rise actually matters in patients with neuromuscular disease. And I'm going to throw that out there because it can make or break you. The rise can make or break the attempt. Patients with very high chest recoil may do very poorly if you throw breath at them quickly. If they have very weak muscles in the throat or the epiglottic area, there's a lot of factors up here. If you slam it with air, it rushes at it fast, you're going to cause a glottic clot. They're going to gag, they're going to choke, they're going to just, they won't tolerate it at all. So for a lot of patients, you may have to slow down the rise. The slower the rise, the longer the slope is, and the less tidal volume you're getting. So the longer the rise, you may actually interfere with your volume, but it may be all they tolerate. Other patients who have spinal cord injuries, some of your limb-girdle muscular dystrophies, some of your CMTs, your post-polios, scoliosis specifically, they actually really like very fast rise. And patients with Duchenne's usually like very fast rise, at least initially, because they want it fast. They want it to be very functional. And if they're air hungry, they want it fast. So you'll have to adjust your rise depending on what you think the patient's going to like or tolerate. But your target in general, your target volume with whatever pressure you achieve for whatever duration of that IPAP you can achieve, you want somewhere between 8 and 10. I'll tell you, if you shoot for 8 to 10, you're probably doing well. A lot of patients will not be able to achieve that out of the gates. And I'd rather have somebody who's on 5 to 6 cc's per kg, if that's all they'll tolerate for several months till they get used to the device and then bump it up after that, they're usually willing, then have them try to get to 8 to 10 cc's so it looks perfect and then them not wear it at all. So you got to kind of just gauge the patient response and comfort level and take what you can get, but your goal is eventually to get them up to 8 to 10 cc's per kg, ideal body weight, knowing that over the long term, that is sufficient to provide adequate ventilation without hyperventilating them, which is another important concept. You don't want to hyperventilate them and reduce their daytime drive. So that's part of the considerations when you're picking your targets. You're targeting your tidal volume. You can target either ABG. Nobody checks ABGs these days, do they? Not for this. I don't anyway. You can do transcutaneous CO2. You can do end-tidal CO2. You can pick some other target arbitrarily. But again, what you're really trying to do is get your patient to use the device. So you might have to put that physiologic target a little bit closer to the back burner and say, you know what, we're going to use this first. And then over the next 6 months, we're going to focus on getting you to the perfect setting with the perfect, transcutaneous CO2 by the end of the night. I'm not going to talk too much about auto-titrating mechanisms, but I will say that a lot of our patients run into problems with mask use, especially patients who have difficulty speaking or being heard at night by caregivers, getting their masks on and off, and they're very limited in what they're able to use. Auto-titrating mechanisms are dependent on the exhaled tidal volume, not the delivered tidal volumes or the delivered pressures. And so auto-titrating mechanisms are often very difficult to use in neuromuscular patients, but if you can use them, solid. There's some safety in it as long as you know how to narrow your allowance on them, allow your pressures in the right range so they're not at the tail end, so the high end or the low end as you go. But just keep in mind, a lot of these patients really need you to be flexible in what they're able to use for interface. Okay, we're gonna move there. How it terminates, we talked about briefly, but in these patients, you want the cycle to be very low. Over here is where the cycle is. If you have a high cycle, that means when the patient's flow decreases to 30 or 40%, it will cut off the breath delivery. That's them cutting off the breath because they've started to taper off the inspiratory flow. You want that to be very long. The longer or the lower the cycle is, the lower percentage that flow is still acceptable. And so if you decrease it to 10, 15, it will be out here, which you would see would increase the tidal volume in those. So for these patients, it's trigger high, cycle low. Trigger high sensitivity, cycle low. As long as you can. You want as long as the breath as you can. And these would be for breaths that are not locked to an inspiratory time, right? These are the pressure supported breaths. And if you can set a range, so ResMed devices, those you can set a TI range. There's a default that allows you to breathe very short. It allows you to cycle off at like 0.3 seconds. It's very short. So for those patients where you're allowed to have a TI range on a device, narrow that range so that the TI min is never 0.3. You never want somebody cutting off at 0.3. You want it at least, 0.8, 0.9 second breath at a minimum, and then work up from there. In neuromuscular disease, we'll see this on a vent in the ICU. This is pretty, obviously, you can see the termination criterion. When you get to that cycle, right? When you cycle off, we're talking about 45 versus, what did they use here? 45 versus 35. You get to 20% of flow, you get to 1% of flow, and that increases the tidal volume. And when you actually go to, so let's say I cycle off at 45% of predicted, the patient gets air hungry because their tidal volume is very low, and so they start to double trigger. And the same can be true on pressure support. The respiratory rate can be very high because the tidal volume is inadequate. And so they'll double trigger breaths on BiPAP even. They'll double the trigger the breath so that the second one is the subsequent breath will deliver, and it will still have a cutoff of 45%. But now you're breathing at 20. Now you're never going to get a backup rate breath. You're never going to get one linked to an inspiratory time because you're constantly double triggering. And so you're never going to meet that threshold to trigger breath. So this can lead to quite a bit of desynchrony and a very high work of breathing if you're cycling off too fast. Ooh, I'm sorry, guys. There we go. So the question comes up, is the respiratory rate important, or is just targeting a higher minute ventilation just as good? And they've tried to look at this a couple of different ways. Most of the studies don't look at long-term outcomes. They look at very short-term outcomes, how fast somebody can get comfortable, quality of sleep on, post-sleep surveys. They can look at your tidal or transcutaneous CO2, looking at a comparison between the two. And honestly, head-to-head, they're both the same. They're both the same. It depends on which study you look at on which day. They're both pretty similar, and they're both pretty comfortable. The difference when you're targeting a minute ventilation specifically is they're typically talking about ResMed devices that use IVAPs, right? They're talking about targeting specifically a minute ventilation and allowing some auto titration to target that with a safety volume built in there. And there's probably no difference. But this study, I forget who the primary author was. I'm sorry, it's on the page there somewhere, but it's by Michelle Chatwin and her group over there. And if you look at what ends up happening, if you compare head to head on pretty much similar pressures, you can see down the line, the respiratory rates here and the IPAP is pretty similar to what they end up achieving with IVAPs. But if you take a look at the comparison between the two with standard NIV, so that's BiPAP ST, the respiratory rate comes down quite nicely, whereas in the IVAPs group, the auto titrating, it's actually very high. And they question why. And part of it is that in the groups that look at this, they commented that nobody was paying much attention to the default cycle. So the inspiratory time for each of those breaths was not controlled. Whereas if you were able to bring down the respiratory rate, at least a certain number of those respiratory rates were locked to a decent inspiratory time. So it's just as important. And the other thing is that auto titrating mechanisms, you will be on both ends of that curve, right? So that it's an average that you're looking for. And so you may spend a significant amount of time at a much lower volume and it will auto titrate up and down. So you may spend a lot more time on the lower tidal volumes and then have to auto regulate that way with your respiratory rate. And it will provide at a higher respiratory rate, lower volumes because you're achieving your minute ventilation. So then it pulls us back. Well, is the respiratory rate staying higher? Are we really doing a good job ventilating? Are we actually pulling them out of that spiral? And nobody really knows. Nobody knows. We have a lot of theories, but we may not be doing as good of a job as we think we are if we're allowing the respiratory rate to stay high. So the general approach to diaphragm rest is to try to take over some of the power that the diaphragm's lost and actually let that diaphragm rest. And then ideally, what we're looking for is that respiratory rate to come down if it's high, right? Or to prevent hypoventilation if the respiratory rate's low. And whether you do that by supporting volumes, it's up to you. We worry at times that the argument is always, if you don't lose the diaphragm, you're going to lose it. And that's come up multiple times. So if I'm resting the diaphragm and taking over for the diaphragm, isn't it just going to weaken it faster? Am I going to become dependent on this machine? And we know from other studies that people tolerate exercise fine. They actually do pretty well with exercise. We can do inspiratory muscle training, expiratory muscle training at low to moderate intensity for multiple neuromuscular diseases, and they improve. But the key to all these studies is that if you're going to exercise the muscle, there's a significant period of rest. You never do it for more than 10 to 15 minutes. If you're going to exercise, you have to have a period of rest to allow recovery of the diaphragm, and at low intensity, moderate intensity exercise. That's what's been proven to be effective. You don't regain strength, you preserve strength and you preserve function. And that's the key there. The concept of resting at night is there, and we do know that it does make a big difference in protocolized exercise. But what does that mean in terms of diaphragm function? Because the diaphragm's always active. So can we rest the diaphragm, and can we actually say that supporting it for nocturnal rest makes sense? I mean, they're a captive audience. You're stuck in bed for 8 hours. It seems like an ideal time to rest it in general, especially when they're at highest risk during REM, right? There is this, we brought this, it turned out to be a much bigger debate than I thought it was going to be. We presented this year at CHEST. It's been presented many times before, but applying it to neuromuscular disease. I don't know if anybody's familiar with it, but there was a bunch of pacing studies that came out mostly in the early 2000s, mostly. And then mid 2000s, they tried to revisit it, but it was mostly for ALS. They were trying to put in pacers. And what they found was that people died really fast. So if you try to put in a pacer and you stimulate the phrenic nerve, people's respiratory function declined like really fast, to the point where they stopped the trials early multiple times. And every time they tried to revisit a trial, somebody comes up with a subset of patients that may benefit for the short term, but it's not panning out. And the question is always why? I mean, these are pretty terrible results. And there's still some people holding on to the hope that this is going to pan out at some point. But it brings up the question of why? Is the tachypnea the problem? Is it stimulating that nerve? And is it disease specific, right? If you have a chronic progressive neuromuscular condition, is additional stimulation and firing of that nerve important? And if you artificially stimulate it, it makes it progress faster. What happens if you're constantly stimulating it by breathing twice your normal respiratory rate, 24 hours a day? And nobody knows. It looks bad if you look at the data that we just went through, right? And we know that from E-stim studies, electrical stimulation studies, there is a good and there's a bad. And overdoing it, you can fry a nerve completely. And this study was looking at that. You can overdo it, but it does actually cause nerve regeneration in some of them. We just got to figure out the right frequency, the right strength of the E-stim in order to make it happen. So we don't know what that is. So far, none of our stimulation studies have actually panned out. And we don't know the duration or the utility of it in certain nerve, and whether there's various types of nerves or stimulation there is. So throwing this out there is an argument that perhaps slowing down that respiratory rate is actually what may be beneficial in the long term. Okay, so how do we actually know we've achieved diaphragm rest? Our protocols may be different from other places in the country, but what we've actually tried to achieve is we use sternocleidomastoid EMG, and what we're looking during PAP titration, we're actually trying to escalate the IPAP, so we're increasing a driving pressure to the point where we actually have significant enough tidal volumes. We've improved the tidal volumes enough to drive that sternocleidomastoid into submission, is basically what we're doing. So if you look down here, we're looking at the sternocleidomastoid activity, and the EMG is quite active. And then when they get into deep sleep, and we've gone from 8 to 15 of IPAP, and now the respiratory rate has come down and the sternocleidomastoid activity has gone down. We're still in N1, N2 sleep, and we've basically achieved our goal. So we're looking at diaphragm rest. Now the sternocleidomastoid and the diaphragm, not the same thing, but we're actually looking at some sort of muscle activity to make sure that we've hit that target. So that's usually what we end up using. When we're looking at a download, because not everybody's going to get a sleep study for titration, but this is one of our more favorable downloads. One, it's favorable because this patient's actually using the device and they're using it for 7-8 hours, which is a victory in and of itself. So even if these volumes didn't look perfect, I'd still be moderately happy with this. But you're looking at exhaled tidal volumes, which for this guy was actually close to 9 milliliters per kg. Your IPAP pressures we've actually, controlled for. His AHI is relatively low. And we're looking right here at the patient triggered breaths. So the patient triggered breaths is how much he's over breathing compared to how many are dependent on the backup rate. And he's 9. Some people would argue that that may actually be overachieving and that he's actually resting too far in this. And other people would argue that this is a sweet spot because now most of them are delivered as basically pressure controlled breaths. They're all locked to an inspiratory time. He can trigger during the day. You don't move your legs all night, every night, but you're still able to walk in the morning. So you could be achieving diaphragm rest if you buy into that. So this is considered a favorable download in one of those patients. So our 68-year-old guy with CMT, who's quite restricted. Remember this guy from the beginning that I didn't cover? He ended up getting a PSG that showed who's having some significant issues with an AHI of 54 in the supine position. And then his desaturations, he got down to 83%. And then you can see his transcutaneous CO2 is quite elevated. By the end of the night, he was quite high. His baseline, this is not a very accurate reading, his baseline was actually about 42. And by the end of the night, he was up in the 50s. How we were able to get this, I'm still not sure, but we finagled it somehow. So the question here is, should we actually be targeting a normal CO2? There's a lot of theory, and this is another topic of hot debate because nobody really knows the answer. We probably know the answer long term, and especially in COPD, but in neuromuscular disease, this is still, I'm not sure exactly why it's a target of like a matter of contention, because we shouldn't be waiting till they have CO2 retention in the first place. But should you target normal? Yeah, probably. The answer is yes, if you can, probably, but you don't want to do it fast. Long term, there's obviously benefit. We know this from mice studies and from ICU admissions. There's a higher mortality, higher risk of infection. There's the theoretical and bench evidence that there's some impaired alveolar fluid resorption and cytokine expression. It messes with your phagocytosis and intracellular pH. So long term, and then there's the catabolic effect that it tends to have on muscles. And that's pretty good evidence. That's dating back to the 1990s. We've known that if you have elevated CO2, you can muscle wasting will progress pretty rapidly. And it's part of the theories behind why the critical illness myopathies and polyneuropathies can be pretty significant. This has been looked at multiple times in different ways. Not that we understand it any better, but we've looked at it. So it's probably good to normalize your CO2 for the other health benefits. But in general, especially in ALS, spinal cord injury patients, and CMT at least, we do know that there's some association with a prolonged survival if we do correct the CO2, which is actually relatively new. So it's one thing, it's associated with a high mortality if you have elevated CO2, but it's a whole other thing if you correct it and can improve that mortality. That's probably pretty good. The downside to these studies is that most of them were looking at patients who were not wildly hypercapnic at baseline. And so the timing of correction, do I need to correct somebody who, if I'm my average patient who comes in is somewhere between 45 and 50 at baseline and the transcutaneous CO2, is that really a clinically significant correction if I'm pulling them down towards normal over the long term? There is some evidence, there's older studies that actually looked at that. Anane back in the late 90s looked at correction of nocturnal CO2 and neuromuscular disease, specifically scoliosis and myopathies and myasthenia crisis. And they looked at daytime CO2 after initiation of NIV to correct nocturnal CO2. And they showed that at 1 month and 6 months, there wasn't any change in respiratory strength, but they actually had better functional status and their daytime CO2 improved. And it had something to do with the reset. So it's potential that we really should be striving to correct that CO2. The question is how fast, and nobody knows the answer. As what we suspect is that it's safe enough as long as you're not making them so alkalotic by the morning that they stop breathing because they're alkalotic. That's the theory. So this is our patient who came in and he got his titration, and you can see he had quite a bit of hypopneas in here, and they titrated him up to the point of diaphragm rest. You can't see that on the actual epochs here, but you can see by the end of the night as they titrated him up, now he's actually in deep sleep and he's consolidated sleep and he's got some nice REM there that we were looking at. This was his post when he came in as a follow-up, and we would put him on 18/5, and we're looking at a respiratory rate of 14. You can see his AHI stayed nice and low. He's got good tidal volumes, good, decent amount of leak on there, but his respiratory rate and his trigger have come down nicely. So he's averaging 14, which is what we have him set at. His trigger is down to 21%. You can see his transcutaneous CO2 spot check is markedly improved. And this is at 3 months, which is pretty good. It's another thing we look for. So I'm going to go through this one last one just because I find it remarkable for these cases. But 55-year-old guy who is limb-girdle muscular dystrophy, and there's a whole ton of types, subtypes of limb-girdle if you're not familiar, but restricted. 33% of what's predicted in his MIPS are low, and he came in and got a PSG, and it looks quite a bit like this. And so even though we titrated this guy up, then he looks pretty good. His AHI got much better, but he's still having some significant events there. But look at this, I mean, look at his sleep patterns. He got so much better by the end of the study. So they did a very good job with the titration. And he got sent home, and he comes back with this. And if you'll notice, his AHI is like absurdly high. Like, these are the same settings he got discharged from the sleep lab on. So what happened? His tidal volumes aren't bad. His minute ventilation looks okay. He's not triggering a ton. And his I to E looks okay, but this AHI is appalling. And so we went back and took a look at his actual sleep study, and you'll notice this was happening. And this was on 15/5 in N2, and you'll notice there's no flow. And so these are actually where the backup rate, which is, I believe it's 12 here, the backup rate set at 12 is attempting to deliver breaths when he gets to 5 seconds, but there's no flow. It's not going anywhere. So like so many of these limb-girdle muscular dystrophy patients, we're worried about glottic closures. And what we looked at in the fine-tune settings, when he was sent out, his respiratory rate was 13. His cycle was medium, so it's a relatively short window, but his rise was 300. And what this was essentially doing was causing glottic closures by the rapid flow. And he had quite a bit of apnea because of it. This is pseudo central apneas. So we decreased his respiratory rate. So if fewer of them were actually unexpected breaths to him. We increased his IPAP slightly, but I decreased his EPAP because that's another reason you may have significant glottic closures. We slowed down the rise. And on his subsequent ones, you can see the AHI was nearly obliterated. We did some positional things, but that's kind of where he went. And then his tidal volumes came up nicely. They were in the 560 range. And then his respiratory rate came down. It stayed low. It was already pretty low, but it stayed low. So that was one of them. So this is kind of the summary of what we were talking about before. Trigger sensitivity high, cycle low, keep your EPAP as low as you can tolerate for these patients, and keep your TI long. These are my summary tables. They are available. They will be available to you. This is the one that's published in Hansen Fleisch and Jason Ackerbo's study. You'll hear from Jason sooner than later. It's a nice summary if you're struggling to get the basics down on some of those auto titrations. The only last comment I'll make, so you can open up the floor there, is sometimes people just don't tolerate anything. And sometimes we just got to be very creative about what we'll do. And if you really are aiming for perfection, you might miss a potential to intervene on these patients, right? And you really just don't want progression of disease. So whatever you can get them to tolerate, to acclimate them, to desensitize them, you might just have to be creative. There's a way to actually do a high flow nasal cannula without oxygen on one of the home devices on Avivo. And so we've been using that a little bit to desensitize some of these patients and get them more comfortable. Sometimes you just have to bite the bullet and pick really soft settings and ignore the backup rate and just try to lock them into a decent eye time and just say, you know what, it's not going to be great, but we're going to get used to this. And then later we'll make adaptations as they come. And there's probably a best approach, and there's probably a right approach, and there's probably an okay approach. And it's better than not trying. That's it. We can skip this. These were videos for fun, but it's, I think we can probably skip. I'm sorry, guys. Ooh, there you go. That's it. If you have any questions.
Great. Thank you so much, Dr. Lussier, for this excellent, in-depth, and very clear presentation on this difficult topic. I would invite anyone who wants to ask questions on their own. And I have one question from Dr. Yagi. Can you discuss the potential risks of non-invasive ventilation among patients with bulbar dysfunction with neuromuscular disease? And how do you assess the risk? And when do you move to trach and mechanical ventilation if this is concordant with their goals of care?
I think that there is a huge quality of life benefit if they can tolerate it. They will never be able to tolerate it if they have a high secretion burden. So there's a big difference between bulbar weakness and having to overcome bulbar weakness with your approach to non-invasive ventilation versus dealing with secretions. For example, FSH patients, the facioscapulohumeral, they end up with very slack bulbar muscles, but they don't have a lot of secretion problems for the most part. They just swallow them and they don't drool. So I don't have to clear up the secretions quite as much. So it's not just the bulbar weakness itself. The risks are high for glottic closures. And as long as you're paying a lot of attention to that and addressing it, really slow rise, really low EPAP, be creative and know that some is better than none. So you don't have to go crazy with a high rise and a long inspiratory time and high pressures. Some is still better than none to get that volume up a little bit. And even if you're only using nasal pillows, and I have terrible leak, but then getting acclimated to it and using it still pretends some quality of life benefit. Usually patients end up deciding early on trach if they have bulbar weakness because typically they're otherwise still pretty functional. And so I would say in our cohort, we looked at this recently, we actually only have 15% of our ALS patients actually go through with trach because we can actually do really pretty progressive things with non-invasive, whether it's pushing for Botox, even radiation therapy for some of these patients to get rid of some of the secretions, and then they do pretty well with non-invasive if they can get used to it. Most of the patients who can't get used to non-invasive ventilation are not really inclined to be hooked up to a machine in the first place, and so they are not super excited about the idea of trach. But that discussion is a ongoing battle, and it's super physician dependent, super provider dependent, and also very patient dependent. So people's reaction out of the gates is usually what they think in the beginning is not always what they think towards the end either. I don't know if I answered some of that question for you, but but really focus on the rise and the EPAP on those patients and slowly work it up to make sure that you're not precipitating glottic closures is the big one on those in that patient population.
Yeah, just making sure that they're sticking to the device in the initial phase.
It's the best you can. 4 hours is better than no hours. 8 hours is better than 4.
I don't see any other question. I have a question. So, despite this knowledge, perhaps better outcome with targeted rate, inspiratory time, which would be probably better with pressure control. We have to go through all these hurdles to get just a simple pressure control mode for our patients. Do you have any suggestions for that to go around and sort of get that mode?
Yeah, it's depends on whether or not you really want to get a RAD device or you really want to get a ventilator. For patients with rapidly progressive disease, you're probably leaning towards getting a ventilator out of the gates. For patients who are not going to pursue tracheostomy or don't need it 24/7, you may not actually want to do that. They may be less intimidated by a RAD. And so you may actually want to buy some time with a RAD. There's evidence to say that your pressure control may be less well tolerated, actually. And it's because, especially if they're awake and they're using it at all while they're awake, it's a very consistent inspiratory time for every breath. Typically, we target a backup rate to either what they're achieving during REM or 2 below their average, so that when they're awake, most of them are pressure supported and they're synchrony. And then when they're in their deep sleep, then they go into an inspiratory time. If you're on pressure control, even when you're awake, you're locked to that inspiratory time. So it's not the most functional of modes for people who still have tone and some control. If you're trying to get a pressure control device, you're going to have to try to get a ventilator. And for those patients, you got to be smart about how you're doing it. Some DME companies are easier to work with than others, and some insurance companies are easier to work with than others. And so picking the primary mode that's only available on a ventilator, they don't seem to like pressure control anymore. So you have to add on an AVAPS AE. Again, that AE in the AVAPS, you gotta be real careful in neuromuscular disease and know what you're doing, because those auto-titrating algorithms are super sensitive to trigger flow and leak. And so if you're going to do that just to get yourself approved, to get your pressure control mode, just really be careful about knowing what your target is and making sure you're achieving that target, because it can actually cause more harm than good.
Yeah, playing around with the DMEs and the insurance company.
Yeah, there's some tricks to getting the mouthpiece set up. Sometimes is enough to get somebody on a secondary, a secondary setting, you need a ventilator. So if you order a secondary setting, especially one that's only available in a ventilator, sometimes it's a little easier to get it approved.
Creative there. Any other questions? Okay, there's Dr. Monse Diaz. You mentioned the topic. Any suggestion on IVAPs? On Philips, AVAPs had more control on settings, progressively increased tidal volume, starting at 7 cc, and then saw a decrease in spontaneous rate and decreased wrist beat. Now that we're using more of IVAPs, ResMed IVAPs, find it harder to decrease the spontaneous respiratory rate. Any suggestions for a setting for patients on IVAPs regarding the tidal volume and the intelligent backup rate?
Yeah, so intelligent backup rate is a really difficult one because it actually rests at 2/3 of whatever your set rate is. So if you're going to use IBR, you actually aim higher than your anticipated rate because it's the threshold, it's the cap. The IBR is the cap respiratory rate. So it won't actually provide a single triggered breath unless your patient drops below 2/3 of whatever you set it at. So IBR is almost like it's kind of like a release. So it's truly a backup rate in every sense of the word. But the nice thing about IVAPs is if you're really tight with your range on the TI range, if you pull up that TI min, you can actually guarantee the ventilation, the volume a little bit easier. It does take longer to get to your target minute ventilation if you have very wide range in IPAP or pressure support. If you have a very wide range set in there, it will leave you on both sides of the margin so you're not consistently hitting your target minute ventilation and your target volume, your safety volume. So if you leave the range very wide, you're going to spend time at the low end before it bumps you up to the middle. And it happens rapidly enough, but it cycles throughout the night. So our practice is typically you can get the respiratory rate to lower if you're conscientiously attempting to increase the safety volume. You can set it higher than you think, but ideally set a higher range of pressure support. Don't leave it really wide. And also, when you're doing it, make sure the TI range is actually narrowed towards the high end. That makes some sense. There's a paper that should come out. Oh, this is self-promotion, shameless. There's a paper that's going to be how I do it in chest. And it's going to actually focus on the transitions between AVAPs. They don't allow you to use the actual terms, but it's AVAPs to IVAPs to TTS VAPs, which is on some of the other ventilators, and some of the other VAPs algorithms that can be applied to the mode. That might be helpful. Sure.
Great. Thank you. It's 3:04. If anyone has any question, please bring that up, or else. Thank you so much again, Dr. Lussier. This was very, very helpful and very thorough presentation. Thank you for accepting the invitation. And thank you everyone for joining.
Thank you.
Have a good one. Bye-bye. Bye-bye.
Bye-bye. Thank you so much.